related to fissures, and then neo innervation and vascular ingrowth, and then separate process of the vertebral body end plate, and separate innervation pathways, which are important. So when we think about classic features of discogenic, quote unquote discogenic pain, I think most would agree that we think of a patient who presents with flexion-based pain, bending forward, sitting in a chair, or maybe in a vehicle, in a car for a long ride, classically would exacerbate this type of pain. They may describe pain that's worse with coughing, sneezing, and that it waxes and wanes, so it comes and goes over days or weeks or months or years. And there are periods that are worse, periods that are better, etc. The reality is that this description of discogenic pain, we don't really know if this is annular or vertebrogenic or some combination. These studies that correlate elements of history and exam for that matter, historically use provocation discography as the gold standard or the reference standard for diagnosing discogenic back pain. I'll show you a little bit later in this talk is that that is perhaps flawed. And so this classic description, we don't really know if these individuals have annular pain, vertebrogenic pain, or some combination. What we do know, we do know a bit more about what dominant vertebrogenic pain looks like. So there isn't a great way to isolate annular pain. We could talk a bit about provocation discography, and possibly low pressure provocation discography helps distinguish annular pain, pain related to the fissures, as opposed to end plate pain. But there is a way for us to isolate dominant vertebrogenic pain. And this is a collection of studies that we did a number of years ago, where we looked at patients across 3 different randomized controlled trials, prospective trials, I should say, who all underwent basivertebral nerve ablation. So interruption of that nociceptive pathway from the end plate, back to the spinal nerve root ultimately. And we isolated the individuals who had a robust treatment response to that therapy. And we used that as our gold standard of, or reference standard of an individual with likely dominant vertebrogenic pain as opposed to annular. So a basivertebral nerve ablation is not going to take away annular pain, which again, nociception travels through the sinovertebral nerve. So all 3 of the studies that we grouped together, pulled the data, and then analyzed, they had common inclusion and exclusion criteria. So it's important to understand the population that we looked at. Everybody had either a type 1 and or a type 2 motor change. They did not have significant radicular pathology or symptomatic spinal stenosis, no instability or surgical indication. So this was a fairly tightly controlled clinical trial population. Just important to acknowledge that. And what we found, if you're interested, in the interest of time, I'm not going to show all the data from those 3 papers, so we could go into great detail. But the high points are that this group of patients had chronic axillary back pain, no surprise. It was very midline dominant, and I'll show you an image of what that looks like. With possible luteal referral, but really very midline dominant. They reported that their pain was worse with activity and not worse with lumbar extension. That's perhaps intuitive. Lumbar extension we think of as a facet loading maneuver, so more likely to exacerbate facet pain as opposed to anterior column pain. And then interestingly, there was no relationship between type 1 or type 2 motor change, whether they had type 1 or type 2. They were equally likely to respond to basivertebral nerve ablation, again, our proxy of dominant vertebrogenic pain. We did find that if they had fluid in their facet joints on MRI, that corresponded to a lesser likelihood that they were a robust treatment responder to basivertebral nerve ablation. And that perhaps makes sense. Again, if there is a component of facet pain, then I think that explains that finding. Interestingly, we did not find that there was a relationship between the degree of disc degeneration, or Furman score, the size of motor change, the size or number of implant defects, simply the binary presence or absence of type 1 or type 2 motic was really what predicted response to basivertebral nerve ablation, and thus, again, our reference for the diagnosis of dominant vertebrogenic pain. So these are the factors that you might consider when making a diagnosis of dominant vertebrogenic pain. This is a pain map. So what we did, all patients in these studies received a pain map where they would mark a body diagram to indicate where they were experiencing pain. And then we converted these into essentially, imagine a grid laid over that pain map or that body diagram, and we hashed in the areas where pain was located for every individual patient. So either they had pain within a certain cell or they did not. And that allowed us to then overlay these and create these heat maps. So where you see the darker maroon or red color, that's where more patients reported experiencing low back pain. So of the 290 in the entire cohort, combined from the 3 studies who had a basivertebral nerve ablation, this is what the heat map looked like. When we looked specifically at the treatment responders, and in this case it was individuals who had non-specific disability index score improvement of at least 15, there's much more density at midline when we compare it to the folks that were non-responders. So everybody had a fair amount of low back pain on their heat map, but when we look at the non-responders and responders, it's even greater. So this is an image essentially of what one might expect to see in the case of vertebrogenic low back pain. All right, so still much work to be done. At the end of the day, these studies were using ablation of the basivertebral nerve as a response, a robust response to that intervention as the gold standard or the reference standard for essentially diagnosing or categorizing the phenotype of low back pain as vertebrogenic. That's, obviously it's a flawed definition, it's the best we have, but at some point we'll need to come up with a better way of categorizing a patient as having pure or dominant vertebrogenic pain. And of course, in this population, these were very clean clinical trial patients, so they didn't have unstable spondies or mildly unstable spondies. They at most had mild to moderate scoliosis, but it had to be, I take it back, they had no scoliosis. So what about our patients who do have at least mild to moderate scoliosis and motic change and dominant axial low back pain? It's a population that hasn't been studied yet. So we will move on to interventional diagnosis and selection methods. I won't talk in great detail about novel imaging biomarkers, but know that this work is underway, and there are a lot of bright people and scientists that are working on better ways of trying to make the diagnosis of vertebrogenic versus annular low back pain through non-invasive imaging means. But what about intervention or interventional diagnosis? So in pain medicine and spine care, we often block nerves to make a diagnosis. And the classic example would be medial branch nerve blocks to diagnose facet joint pain. We really can't do that with the basivertebral nerve. So there's a lot of problems with trying, but having to access the pedicle is very painful, usually requires at least conscious sedation, if not general anesthesia. And even if we could do that painlessly and without sedation, it would confound our diagnostic block. The basivertebral nerve it sits within a highly vascular area. So within the trabecular bone of the vertebral body, there is a very healthy blood supply. And really, if injecting an anesthetic, for example, around the nerve, it's going to be washed away very quickly by the blood supply in that area. I've tried it, and that's what I found to be the case. I tried injecting contrast near the nerve, and it washed away within 10 to 15 seconds. Transdiscal block. This has been brought up as another possibility. Can we essentially block basivertebral nerve termini through intradiscal injection? And Possibly, yes. The trouble is that we're also going to probably anesthetize the sinovertebral nerve fibers that are potentially exposed, especially if there is an annular fissure and there has been some neo-innervation from the fissure. So translucid block is probably not going to help us distinguish between annular versus end plate pain. Finally, provocation discography. So this is a tricky one. So this has been the gold standard for diagnosing quote-unquote discogenic pain for many years at this point. And it probably does have value. The tricky thing is if you overpressurize the disc, that does cause end plate deflection. So I think we're all familiar with the concept that provocation discography causes stretch. And if you have a fissure in the annulus and it's a painful fissure, it's going to hurt. And it's going to hurt at relatively low pressures. If you keep pressurizing that disc, there are studies that show mechanically that it does cause deflection of the end plate, and that could potentially trigger nociception through the basivertebral nerve. So the take home here is that possibly, this hasn't been validated, but in theory it makes sense that low pressure provocation discography probably has the best chance of delineating or distinguishing annular pain from a fissure that's painful compared to end plate pain with nociception through the basivertebral nerve. So I would just encourage everyone, if you are going to do provocation discography, to follow the ISP, SIS, or IPSIS standards. And the big take home here is that you don't want to overpressurize the disc. So there's a volume limit of 3 mils. Most discs you don't need to put in 3 mils. They wouldn't even accept that volume. And you don't want to overpressurize the disc, meaning keep pressure less than 50 psi above opening pressure. Because, as mentioned, you're going to start to have end plate deflection, and any disc, no matter what the disc, if you pressurize it enough, it is going to hurt, and then you're going to have false positive results. Just looking at the literature broadly, this has been looked at by others. When using all sorts of different provocation discography techniques, the false positive rate is very high, 29%, arguably unacceptably high. If you use the ISP IPSIS standards or SIS standards, that false positive rate drops dramatically to 6% per disc. So in other words, low pressure provocation discography is going to be more reliable as a diagnostic test than other types of discography. There are worries about, many are concerned about discography because of studies from Gene Carrigy and Stanford that showed that provocation discography accelerated disc disease or disc degeneration over time, led to more herniations, more annular fissures when patients were followed over time compared to matched controls. Those studies were done with higher pressure provocation discography. So we actually went back and did the same sort of study, methodologically very similar, with greater power, greater matching to controls. But we looked at specifically patients who had undergone low pressure provocation discography, had MRIs at baseline, MRIs 7 years or greater after the provocation discography, and then matched controls. And we found that there was no difference in the natural history of disc degeneration or disc herniations or the presence of high intensity zones, annular fissures on imaging, minimum of 7 years later, but potentially much longer. So if performing provocation discography with low pressure and with a 22 gauge needle, no larger, it appears that you shouldn't be concerned about this possibility of accelerating disc degeneration. So I'll leave you with those take-home points, and then we'll get to the second part of this lecture a little bit later. Thank you.
我们有10分钟的时间可以 Q&A。那如果是要问 Zack McCormick 的问题的话，就先记下来。好，那现场有没有其他的问题要问 George？Chinese is allowed。那你直接讲他听得懂中文，他也可以讲中文。 只是他英文讲的比较顺，所以他上台用英文跟大家讲。
请问一下，刚刚有提到说高空海水可以增加那个 pressure aggregation，可是他最后一张slide又说要 non-fasting， 那是不是有点冲突？
我不看，有我也问，
用中文吗？
你说中文。
就是刚刚说 carbohydrate 可以 help prevent the aggregation。
Yeah, he says carbohydrate can help the aggregation of protein, but you say that.
So the next slide said the patient better be non-fasting.
So this is what I tell them to do. I don't know if it's okay. This is what I tell them to do. I tell them to lay off the sugars, processed sugar like candies, cakes, all that stuff outside, right? Caffeine, alcohol, for as long as they can before, at least a week or two, and afterwards. Okay. The morning of, I have them fasting for a lot of reasons. One, if you ever process the blood and they have a lot of fat, you cannot see anything, right? Some individuals and right, it's all lipids, right? So you want to see that. So that I have them avoid fat for red meats, all that kind of stuff before, right? Things that have nitrates, like preserved foods. But when I say they can have like the morning of the procedure, they're not truly fasting. I tell them that they can have a little bit of like fruit sugar, eating a 水果, right, and some water, and then that's pretty much it. I don't know if I answered your question, though. But that's what I tell them to do. And then afterwards, the same thing. Try to avoid alcohol, caffeine, some simple ideas. NSAIDs last. I don't know if you guys know how long platelets take to degranulate, but they actually have been shown that they will degranulate over the course of 7 to 10 days. So it's not just this, there's a sudden burst. Now some people out there, they actually create what they call platelet lysate. I don't know if you guys do that in Taiwan, where you obtain the buffy coat and then you aspirate out and you can do it different ways. There's companies out there that talk about doing ultrasound to burst the platelets. There's some places that will do that. I don't know how good that really is. A lot of places, the way they do it, they just put it in dry ice and cause it to freeze, and then you thaw it, and then they lyse, and then you centrifuge it again, you get an ultracentrifugation. The idea is that it's supposed to be more smooth, less inflammatory, and you're just taking out the growth factors inside the platelets. I forget what made me want to say that, but anyways, I don't know. Any other questions?
I have a question.
Yeah.
How many times of the concentration do you think that is the minimum required? Because in Taiwan, most of them use the tube. It's like you get 10 milliliter and you get 3 cc of PRP, and that is like 2 or 3 times only.
There's a one that I put up, the Regen Labs, right? Regen Labs, they use a gel separator. There's multiple people, because they've been around for a long time, there's multiple people who have compared against that product, which is still like $50, $60, okay, US. And I'll tell you something, all these studies, granted they're done, some of them independently, some of them are on competitors. It's not even X more, it's 0.8 normal physiologic concentration. So you actually have less PRP in that than if you just told shit, right? Except you got rid of the red blood cells. Chris Centeno, I'm sure everybody heard of Regenics, right? Chris Centeno, in their like thousands and thousands of patients, they've looked at where they said at the very least when we get 2x, when they looked at they did a systematic review where they looked at all the studies looking at this, and they said every study that was not at least 2x, which is not a lot, right? Essentially, there's a big difference between 2x and not 2x. Again, the dilution is tricky, right? Like I said, you think about it. I have this much blood. I pretty much cut it in half. This is red blood cell, and I have this buffy coat here. When I pull this off, if I pull off 3 cc, 2 cc, 1 cc, like 1 cc at the very bottom, if I pull off another cc, it's already half, right? It doesn't matter if this is 10x or 20x. If I add one more layer on top, 1 more milliliter, double the volume is already half, right? If I go like this, it's even less. So it's really depending on what your tissue target is, right? If you say, listen, I only have 1 tendon problem here. I only need maybe 2 milliliters of what I want. Then maybe that's it, right? It's gonna be super high concentration. Does that make sense? The biggest problem I think in a lot of studies is that, so you guys don't have this problem, but all the studies looking at the knee talk about the knee, right? They just stick it intra-articular. That's it, right? They talk about the hip, they just stick it intra-articular. They don't talk about, is it the MCL, the meniscus, the whatever, right? So I think there's a problem. This is where you can really push your outcomes because you actually have a really finite diagnosis that you're trying to discreetly treat, right? You guys, like I come to Taiwan, you guys talking about like sticking a needle from the back to hit the root tear of the meniscus, right? Like nobody's doing this, you know what I mean? It's really cool. It's bad stuff, but like it's tough, right?
我们大概在2到3分钟之后，我们就开放这两个问题了哈。
其实我刚刚有偷偷问，就是关于萨拉森尼亚的问题。因为通常萨拉森尼亚，我有几个 case， 它就是对 PRP response 比较不好。想问一下，是不是因为他们有萨拉森尼亚问题，所以他们 platelet 效果比较差这样子？
You know, there's a lot of questions that people are gonna have, and there's a lot of like special cases that like nobody really knows, right? Because we get asked this kind of question all the time. I don't really know. I can tell you that if you look at thalassemia, it's like a red blood cell problem, right? And then there's like 20 kinds of thalassemia, right? So they have a genetic problem already. You already think that this person has a problem healing. Actually, in fact, they have a problem with oxygenation their whole life. It's not just today, it's not just this isolated thing I do for you, and then your life starts here, right? I think in this kind of patient, they probably have a hard time healing no matter what. When we do PRP in an injured tissue, the idea is that there's supposed to be some healing process, right? So, you know, whether or not the red blood cells are directly affected by that, I don't know. But I think for sure, even if the idea is that we're going to create angiogenesis, right? Platelet-derived growth factor, vascular endothelial growth factor, we create blood flow here. If your blood is not healthy in the first place, it's probably going to impair healing. But I don't know, you know? It's just idea. I cannot give you I cannot tell you a paper, right? Yeah, definitive answer.
Yeah, thanks for your excellent speech. I have one question. Is that you said that angiogenesis and we must stimulate inflammation via PRP to increase the angiogenesis, to increase the vessel, to increase the circulation. But when we see the injury tissue already have permanent vascularity and loss of control, so do you still inject PRP, or is that worse condition of the vascularity? Is really help the healing, or it is chaos? You need to reset the environment and then inject the regenerating injection. Thank you.
The short answer is I don't know. No. Okay, so this is a great question. So I think what you're asking, so here's a really good question, right? Let's say someone has an Achilles tendon injury, and we put the ultrasound probe on there, and then what do? We turn on the power Doppler, right? And what do we see? We see this, right? Like stars, right? Sometimes we don't always see that, right? I mean, what do we all say? We say, oh, it's neovasculated, right? When we see it, we say it's something. When we don't see it, what do we say? We say, okay, we don't see it, right? So the body is always trying to heal itself, right? But you realize that like the body doesn't always have the perfect map, if that makes sense. When you look at the architecture under ultrasound, right? You see all the fibrils are perfect, right? Parallel, right? You understand what I'm saying, right? And then when you have injury, you see it doesn't look like that anymore. When they do the anatomic studies and the histopathologic studies and they cut it open, you see that the fibers are in disarray. And then you see blood vessels growing through it. If you give this person enough time, so John Jacobson, right? John Jacobson did a study where they longitudinally serial scanned people's rotator cuff tears after rotator cuff repair. This is a surgery repair, right? Think about it. They serially scanned for, I think, 2 or 3 years, okay? And they show that after many years, eventually the parts that heal go back to looking like normal tissue. My point is, what I'm saying is that if you can, my friend said, ideally, eventually, if we can restore the normal stresses and mechanics, the body should heal to that point. When we talk about like adding blood flow to that, right? I can't tell you for sure that's what it does, but I can tell you that in any injury, that's what happens, right? So if you know, that's why I say, like, you get a paper cut, right? What happens? You know what I mean? Or if you think of someone who has decubitus ulcer, right? If you guys ever treat decubitus ulcer, there's eschar, the dead tissue. What do you do with the dead tissue? Right? We debride it, We add collagenase, right? Collagenase is the same thing as macrophage, right? We take away the dead tissue and we try to get it to have healing. Primary healing, secondary healing, right? So I think that all we're trying to do is promote that process. The body's trying to do it, but it doesn't always ever get there. I don't know if that answered your question, but hopefully, I don't know. 可以吗？没办法。
He's a very outstanding radiology.
Yeah.
He is doing individual radiology
Okay.
and also the microvascular embolization of chronic pain. So that is why he has this question. OK， 那我们就大家一起坐中间一点，我们先来拍个活动的照片。好，那拍完照之后呢，我们下午就按照外面海报。